Bay Radiology strives towards providing the referring doctors as well as our patients in the Eastern Cape with service excellence and a full comprehensive diagnostic radiology department. To actually achieve our goal, we're constantly upgrading our equipment to the latest technology. During the course of 2018, we installed a PET-CT scanner, a first for the Eastern Cape, at our rooms at the Oncology Centre in Port Elizabeth. The new equipment affords our patients of the Eastern Cape as well as the Southern Cape to be able to have their PET-CT scans done locally rather than having to travel to different provinces should they wish to do so. Our PET scanner consists of two components. The first is a diagnostic 16-slice CT scanner that can be used as a standalone unit, which we do on a daily basis, where we follow our patients routinely and stage them. The second component is the PET component that contains 5 slices. The 5 rings of the PET scanner allows us to use shorter scanning times, and therefore our quality is substantially better and it enables us a more accurate diagnosis. The PET scanner uses a radioactive glucose-based tracer, generally known as FDG. The FDG has a very short lifespan of approximately 109 minutes, decaying very fast. The 5-ring PET scanner allows us the leeway to do the examination much faster, utilizing less FDG if necessary. When we book the patients, we obtain medical aid authorization for the examination. Once we've obtained the authorization, we contact the patient and we issue them with a full information and instruction booklet. The information part is really just to put them at ease so that they know what they're in for. The important part is the instruction part. It's actually a very complex diet that we give them: the no-go foods, the go foods, what they can use, what they can't use. But the important thing is also that they've got to keep warm so that their muscles don't contract unnecessarily by shivering, and they are also not allowed to do any exercise or strenuous activities such as even sweeping a room, cleaning windows, hanging up washing is out. The patient has to follow a low-carb, high-protein diet. The reason behind that is that we are actually utilizing the diet to obtain an even uptake of the glucose by the rest of the body. This enables an optimum scan and therefore much better results. Cancer grows at a substantial faster rate normally than your healthy tissue. The FDG is absorbed by the fast-growing cancers and it takes up, we call it FDG uptake. It lights up like you can see there. The role of the procedure is to diagnose metabolic active malignancies, such as those we find in lung cancer, colorectal cancer, breast cancer. The ones that we use it mostly for is lung cancers at staging, because it will help the doctor to decide, is this patient suitable for surgery, or are we just going chemotherapy and radiotherapy? The second one is colorectal cancer, that they are all active, metabolically active. Breast cancer, ovarian cancer, malignant melanomas are all highly active. Then the lymphomas is a slight problem. It's mostly just the follicular cell Hodgkin's lymphomas or follicular cell lymphomas that is positive. Luckily for us in the Eastern Cape, that is our predominant lymphoma that we get. Then it is multiple myeloma. That is a really difficult one to know whether it is there or not, because it just causes like a lytic lesion in the bone. And now you're not sure. The patient's very osteoporotic also. Now you don't know, is it just osteoporosis or is it malignant myeloma? And if we know it's malignant myeloma, it lights up with FDG. So it just makes it so much easier to diagnose it. We then will utilize a full body MRI using diffusion weighted series predominantly. If the patients don't follow our instructions by using a low carb, high protein diet, limiting their activities as well as keeping warm, our background enhancement is substantially more than we would like to have, and therefore one can actually misinterpret a lesion like a muscle that's enhancing or skin that takes up more FDG, and then we actually have a very bad quality examination because the FDG is absorbed by organs that we actually don't want it to absorb, and the cancer, sometimes they're not as bright. So if the background is very active, you miss them. The HIV patients also get a AIDS-related lymphoma, they get TB. That is our biggest challenge because those things are super FDG avid. And now you don't know if the gland that you see there is due to the AIDS or whether it is due to lymphoma. And then we've got to actually look at the guy's counts for viral counts. We've got to look at their CD4 count to establish which one is which one.